Asher, and I'm a second-year graduate student in speech pathology. Update on patient case 11382. Another stressed out adult child, alcoholic caregiver. Awesome. All right, let's address her immediate concerns and get her out of here. Any referrals, social worker or psych? Sure, let's just take it over from here. Let them take it over from here. Have your patient load this week. Got a patient with 2 broken feet coming in now. This is whoa. This is not how we are going to approach this case. Due to the complexity of Mrs. Johnson's medical, social, and cultural history, we have decided to take a team approach to ensure collaborative, comprehensive care. A presentation outline. So first, in part 1, we're going to do an overview of the patient case, followed by a needs assessment. Part 3, the identification of the goals, and finally, the treatment plan. Part 1, overview of Mrs. Johnson's case. Mrs. Johnson is the star of our case, and before we can treat her, we need to know her as a person. So in order to address her unique needs, we've decided to get to know Mrs. Johnson a little bit more. Mrs. Johnson is a mother. She's a bingo champ. She's an exercise enthusiast at the local gym. She's a retired school secretary. She's a grandmother, and she's an avid churchgoer.
And to even get to know Ms. Johnson a little bit better, here is a family genogram that provides a little bit more detail about some of the family dynamics in her life. Here are some symbols up here. So we have Ms. Johnson with physical illness, which we'll get into later, and she has 2 sons. This son, Bruce, lives in Florida. He has a disabled wife and 2 kids, and her son, Michael and Talia, live with her in the home, and as we can see here, Michael and Dorothy have a strained relationship, which we will get into in a little bit. So what brings us here today?
Well, Mrs. Johnson is a patient in our SLU ER. She was brought into the ER by her granddaughter Talia, who was concerned about slurred speech and also an inability to get up out of her chair. She was concerned that her grandmother may have had a stroke. So she brought her to the ER, where the admitting physician ran a couple tests and noted that Mrs. Johnson has dehydration and also a wound on her leg. And at this point, she was admitted for a little bit further evaluation. So even though Mrs. Johnson's acute conditions are what bring her to us today, we do need to keep in mind that she does have this complex medical history. She was diagnosed with hypertension, has diabetes, and also diabetic chronic kidney disease, osteoporosis, urinary incontinence, macular degeneration, osteoarthritis, and peripheral vascular disease. So as you can see, Mrs. Johnson has quite the complex medical history, and because of that, we've needed to map out quite the complex map of medical providers. This is Mrs. Johnson's medical care team. Mrs. Johnson is there in the middle, and all of the care professionals and the care providers are circled around her and focused on her. So before I get into the specialties, I wanted to bring your attention to 2 important parts of this care team, which are both in yellow at the top here, her son Michael and her granddaughter Talia. Both are currently living with Mrs. Johnson, and as such will be an integral part of her care planning. Now, you can see that this is quite a map. It's pretty complex, and I certainly can't expect Mrs. Johnson to keep track of all of these professionals who should be involved in creating her care plan. And because of that, we as a team identified 4 people who Mrs. Johnson will be in regular contact with. The first is a primary care physician who she will have monthly visits with. And this primary care physician is going to be responsible for contacting and networking with all the people in purple. So the primary care physician then will organize referrals, help make appointments, and also help communicate information from these specialties back to Mrs. Johnson. The second individual is a nurse. The nurse will be making daily visits to Mrs. Johnson, whether she's in a skilled nursing facility or a home health care nurse, at least until she can get a little bit more independent, a little bit more back up on her feet. The nurse will be coordinating care with the occupational therapist, the physical therapist, the speech and language pathologist, and the nutritionist. Now, these professions normally work together. They're fairly integrated. And we've really just listed them out here under the nurse so that way the nurse can make sure that these daily needs are being met, and that way the nurse is clear on what we expect from each of the individual care providers, and nothing gets left out. The third person that we have here is either a psychologist for a counselor who we would like Mrs. Johnson to have weekly appointments with. And this counselor then will be responsible for psychiatry referrals, as well as suggesting when clergy might be able to get involved. And the final person we've identified is a community-based case manager who I would like Mrs. Johnson to have either weekly phone calls or weekly meetings with. And the case-based community manager will be working with a family medical therapist as well as with a social worker. So as you can see, we have 22 individuals here who are all going to be contributing to Mrs. Johnson's care plan. But to reduce Mrs. Johnson's stress and to make it a little bit easier for her to navigate the system, we've identified 4 primary individuals who she'll be in contact with regularly in case she has questions that arise. And all of these individuals together will be working not only on acute conditions that arise, but also on preventative care. Because we're not just worried about Mrs. Johnson's life today, but worried about Mrs. Johnson's future as well. Part 2 is our needs assessment.
So when we think of Ms. Johnson's medical care, we are looking at her care as a person in the environment. So this is an ecological model that we have been able to map out some of Ms. Johnson's strengths and supports family, bingo, church friends, and neighbors. She attended exercise classes, and her complex medical care team that we just mapped out. So also around Ms. Johnson is her community and different services, interpersonal and organizational, that she has access to. Local senior center and her church, as well as a grocery store. Is Ms. Johnson living in a food desert, which is clearly linked to part of her medical care and in food?
Yeah, and definitely something that speech pathologists would be wondering about. I want to know what her grocery stores have. Do they have food that she's interested in, that she's actually going to eat? And is it also food that she can tolerate?
So what does transportation look like in her community of North St. Louis County, as well as the different medical facilities and the culture of healthcare as could be demonstrated in the Homer G. Phillips.
Exactly. So the medical community needs to be aware of the cultural conditions in North St. Louis, especially things like the ramifications of things like the closure of the Homer G. Phillips Hospital in North St. Louis and what that means for physician trust and confidence.
So we have looked at Ms. Johnson in this system of care, and then on the outer ring is policy and other agencies and think tanks and policymakers that have no direct contact with Ms. Johnson, but policies and things of that nature have direct impact on her care as a vulnerable, as an individual within a vulnerable population. And we took a biopsychosocial approach to her assessment and looked at her as an individual with very specific needs. So from a physiological and safety standpoint, what does her medical condition look like at home as far as safety in the community, and how does she foresee love and belonging to be restored after discharge, and how does her self-esteem and self-actualization, how is that formed within the hospital setting upon discharge? Is that returning back to bingo? Is that returning to exercising classes? So how does Ms. Johnson proceed to move forward upon discharge to restore that individual meaning? And we also decided to use these 2 scales to look at the caregiver stress from a family systems model and to try to understand how maybe those relationships and the strain that Michael may be feeling for taking on some of those caregiving roles have been impacting his life. So this scale asks some questions for Michael to answer about how his daily life has been impacted, and the geriatric depression scale will be re-administered again to see where Ms. Johnson is on that scale.
So in order to classify Mrs. Johnson's needs and also to start planning treatment, we've decided to implement the ICF framework, or the International Classification of Functioning, Disability, and Health. And this is going to help us describe and organize information on Mrs. Johnson's functional abilities, and we can see how this is going to impact her, or how this will impact her abilities after care. So as you can see, we first talk about body functioning and structure. So that would be her mobility, her communication, the wounds that we need to take care of, and then her activities and participation. So we're looking at those activities that she's now limited from doing. So she loves her bingo and going to church, and how she's been limited and can no longer participate. But below you can see that help Mrs. Johnson complete her goals. So we look at the home culture and the situation at home. We look at the social interactions and then her family support system or even the community support system. Additionally, her personal factors. So maybe her religious beliefs. Is she close with her family? Does she enjoy engaging with others? And if she does not anymore, why does she not? And also her financial concerns. So part 3, identification of goals. As we've said many times, Mrs. Johnson is the star of our presentation. And we wanted to hone in on her personal goals and see what she really wants to work on. So first, she wanted to return to church and bingo. She wanted to meet her friends for lunch again. She wanted to visit her son Bruce down in Florida. She wants to depend less on Talia and Michael, and she wants to independently remember to take her medicines. While taking into account both her goals and the goals of the many professionals that are working together, we've come to find an overarching goal of helping Mrs. Johnson return home safely. And in order to get here, we have some sub-goals that we first need to address. First, controlling current medications for hypertension and diabetes management, which would be handled by the physician, the nurse, and the pharmacist. Next, addressing nutrition and safe swallowing function, which would be with the speech pathologist, the dietitian, and the nurse. Determine safest living situation for Mrs. Johnson, the social worker, the medical family therapist, the physical therapist, and an occupational therapist. Managing social, communication, and mental health needs with the speech path, the social worker, and the medical family therapist. Providing caregiver training, so that's training for whoever's going to be in the home, for Michael and Talia, for family members, and for addressing the family support needs. So what support does Michael need, or Talia? What can we help them with to ensure that they are also successful in this process? And that would include the speech pathologist, medical family therapist, social worker, OT, PT, and then finally preventing future problems and illness, which we know would take the entire care team, all to get to our final goal of helping her get home. And as we already talked about this huge group, this is how we're going to get to the goal, by having all of these professionals collaborate together to ensure her success.
Part 4 is the treatment plan. First, we need to address Mrs. Johnson's immediate needs. So in the next couple of days, before she's discharged from the hospital or from a skilled nursing facility, we want to accomplish 3 major goals. First, physical examination. Second, a mental health screen. And third, to assess the safety of the home environment. So the physical health examination would involve doing a swallow study, developing a nutrition plan, and ensuring proper hydration. We would also like to continue administering antibiotics and monitoring the wound on her left ankle, which is one of the reasons why she was initially brought to the hospital. We would like to involve speech therapy and look into, because currently she's having some issues with reduced independence with effective functional communication. And finally, we would like to get another neurological consult for further testing due to CT inconsistencies for recent strokes, just to be absolutely sure that she did not have a stroke and that's not one of the issues that we need to address before she leaves the hospital. We would hate to send her home if she's having strokes. The second part here is the mental health screen. So we would like to work with the social worker, the psychologist, and the speech pathologist to revisit the depression study and the dementia study. Now we've already done this, so why would we do it again? Well, because she screened positive for both of them. So I would like to know a little bit more about this before we go into developing a long-term treatment plan. And then the third aspect is our assessment of the safety of the home environment. So here we would like to do an occupational therapy assessment, seeing how she walks upstairs without a railing, for instance. We would also like to look at medication compliance and also for the abuse, or also for the potential of abuse or neglect within the family and family conflict. Then we can move on to long-term needs. Now, as healthcare professionals, our number one has to be getting Mrs. Johnson medically stable. So we would like to help her in the management of her chronic diseases, such as diabetes, hypertension, and also reducing her risk of stroke in the future. After that, we can move on to the psychosocial aspects, such as reintegrating her into her social activities. From there, we would like to perform a quality of life assessment, consider cognitive stimulation therapy, promote healthy cognitive aging, as well as look into caregiver support and education, and be providing this throughout for Michael and also for Talia. Now, given our goals and Mrs. Johnson's current situation, we would like to place her in a permanent care solution. We've come up with 4 potential solutions. So here are our integrated team recommendations that we would like to discuss with Mrs. Johnson. They go from the least amount of most amount of change, and we'd like to see what Mrs. Johnson is most comfortable with and what we feel comfortable with, and kind of meet in the middle so that way we can find a productive solution long term. The first one here is to get a home health care nurse. So a home health nurse then would allow Mrs. Johnson to stay in St. Louis. This would allow her to stay in her home with Michael and Talia. She would be able to stay involved in her community. The second option we have here is an adult daycare. Now, this is a little bit of a unique option that we came across in our research. And this would also allow Mrs. Johnson to stay in St. Louis. The difference here is that it would get her out of the house during the day. These centers can be open from 6 a.m. to 6 p.m. They can provide transportation to and from. Here she would have somebody who would be able to help her with her medications regularly. She would be able to have her meals monitored. She would even have more socialization. So this is another option we would like to discuss with her. The third option and the fourth option would actually be if the home environment were judged to not be safe for Mrs. Johnson anymore. So we could potentially have her go and live with Bruce. That would involve moving to Florida, however, which would take her out of her community right now, and it might also kind of strain family relationships with Michael and Talia. So that may not be ideal, and Bruce also has a lot on his plate right now, but we do want to discuss with Mrs. Johnson that this could be a potential option. And then finally, we could also look into nursing homes, which could either be here in St. Louis or it could be in Florida. So again, from least change to most change, we have a variety of options that we would like to discuss with Mrs. Johnson and see what she feels comfortable with and what we feel comfortable with, because we need to make sure her health needs are met in a way that she appreciates and that she feels like she's involved in the decision-making process of her care. Now this is just a recap of our timeline of care. So today she's in the hospital. We'd like to complete some urgent tests and ensure the safe home environment. After that, we'd like to discuss some follow-up care. Tomorrow, she's going to be discharged. We will communicate, well, barring any medical problems that arise between now and then. We want to communicate a clear plan for care at home, discuss follow-up care, and also answer any questions from Mrs. Johnson and family before they go home. So we want to have a specific session where we provide education and make sure that the family and Mrs. Johnson are clear on what our goals are and we're clear on what their goals are. After that, we'd like to see Mrs. Johnson placed in a skilled nursing facility for an adjustment period so she can recover and learn self-care. We would also like to organize new care options at this point and continue our assessment of home safety. At the end of the month, we would like to have a team meeting where we can discuss the progress of the last month and future care options. Again, here we would return to the safety of the home environment, or we could transition to an assisted living facility. And then after the end of the month, we would like to see Mrs. Johnson in a more permanent care situation, whether that be a nursing home, adult daycare, or a home health care nurse, which we described on the previous slide.
So this is a bingo chart that we created with Mrs. Johnson, and it's her plan to victory. So we created this with her so she can keep on track. It's not only great for patient education, but she's going to have this posted at her house, and it can also be useful for caregiver education, for Michael and Talia to understand what they can do to be part of Mrs. Johnson's success. So, as you can see, we have what our goals are for her, who will be helping her, and how we will be helping her. So first, our B is that she'll begin taking all of her medications regularly. This will include the home health nurse, Talia, family medicine, and how she will do it, we'll have a daily medicine chart, daily pill case. And then I, she'll install railings in the stairwell or remove the bedroom to the first floor. For N, we're going to work on her nutrition. For G, we're going to work on her going to church, lunches, bingo, and other social events. And O, once a month follow-up appointments.
I would just like to emphasize that I feel our team truly emphasized and collaborated in an integrated care model. So here are some examples of how we did so. Scheduling wise, we had a few conflicts arise within the month period, but we worked through it and collaborated, in the name of Miss Johnson. So with that being said, I feel that we really demonstrated the interpersonal practice, interprofessional.
Wonderful. So we clarified team roles well, tried to use jargon-free language even among ourselves, but especially with Mrs. Johnson, shared pros and cons of treatment options, recognized the need for other professional help and referrals beyond our own experience, and also expressed an appreciation for and willingness to work around others' personal schedules. So with that, we would just like to go to our acknowledgements. Any questions?
So I'm curious, what did you feel like you brought, in terms of your perspectives? Did you have different approaches, or were they all similar? How did that kind of play out?
They were very different. medical student, so I walked into it, and there's a ton of medical information in that case. You guys have all read it. So my focus was totally caught up in the details and the labs and the diagnoses and the medications. And Lauren and Caroline were really good about kind of helping me step back from that and look at it as a more sort of psychosocial approach to Mrs. Johnson's care.
Yeah, I definitely agree. I think with both of our professions, we talk so much about the person and how we are going to address the person's needs. And I mean, it was kind of funny. Like, I was like, why does she care about this stuff? Because it was stuff that I didn't know about. But it was great to learn, one, to know what are some important things that I need to consider, but also to kind of explain, well, what about her? And how can we make this about Mrs. Johnson?
I feel like having, the medical family therapy experience as well as a social work background, I was able to really kind of hone in on some of those family dynamics and truly have that understanding of what it, can be like to have that strain as a caregiver. So I was able to kind of interject thoughts about the family dynamics in that regard, and the mental health aspects.
Did you think she'd be safe at home? I mean, that's what is a real question.
Well, I mean, I think we were trying to have a positive mindset, and that's kind of why we talked about providing the support that Michael and Talia might need. It's very understandable to not know how to deal with someone in her situation, the condition. Maybe she's not eating, and they're unsure how to deal with it, and without someone to tell them or to give them some guidance, how will they know? So I like to at least think, yes, I do believe that maybe there was some neglect, but I don't think it was intentional. I don't think they were trying to harm her. I mean, maybe it was a call for help, and they needed someone to step in and show them some tools how to help her.
I'd say we also actually discussed, and actually previously to provide your PowerPoint, had a whole slide on red flags. So there are things like the circumferential bruising around her wrist, which I just thought was not normal. Things like her showing up and smelling like urine would be signs of neglect. She's not taking her medications regularly, or at least that's what her labs would suggest. So it seems like she might be left on her own a little bit too much. So I would be hesitant to send her home alone and just discharge her. On the other hand, if we could get a home health care nurse who's going to visit her daily until she can get a little bit more on track and a little bit more independent, I think that could be a potential solution. However, Lauren actually had the idea that we needed to make a call to the Department of Health and Senior Services just to make sure that this gets checked out before we send her on her way.
And hopefully that was conveyed in the timeline frame to have that assessment be completed, and then from there, taking that data and then assessing what the long-term plan of care might be. Because if she's not safe to go home, then some of the other placements would be more ideal. Hopefully in that investigation, Michael's alcoholism and history of DUIs, and that would be addressed as, maybe a strategy that he's self-medicating in some regard to deal with the stressors of these caregiving responsibilities.
Support for them too.
I really liked that you included that ecological model of care. That was really great. The bingo card was excellent, very creative, wonderful. I wondered if there was a time when you were preparing the case when you thought to yourself, oh, I wish we had this one piece of information. Was there anything that you remember thinking, oh, we don't know this, and it's a big question mark for us as we're planning?
One big thing for me was I would have liked almost like a specific address or something, because there are so many factors that we talked about, such as grocery stores, even transportation, because she's not driving anymore. So if Michael can't take her somewhere, can she take a bus? Is there easy transportation? Is that something we even feel comfortable with on a PT standpoint? But to know a little bit more about her environmental factors and her household, I think.
I think too, just I guess not exactly like information from the case, but just knowledge that we had. It would have been really interesting and helpful to know a little bit more about the different professionals, PT, OT. And luckily we had one group 3, that we collaborated with and kind of swapped information, so that was useful. But I think even just from a more interesting standpoint, I'm like, wow, I really wonder what they would have done in that situation, because I can only give my best judgment.
I guess looking at the family, and really trying to assess for what safety looked love to been able to sit down with Michael and Natalia to see kind of how they would describe what is really going on in the home, because Talia seems very involved in her grandmother's care in the emergency, in the hospital admission process. So, and to wonder exactly why Dorothy may have, Ms. Johnson may have felt like a burden to her son, and just it seemed like the timeline of that